And welcome to the Ministry of Health's Town Hall meeting on understanding your standard health benefit premium. I'm Tina Evans, Communications Officer with the Department of Communications, and I'll be your moderator for this evening. Our purpose tonight is to review and discuss your standard health benefit premium and the change in funding to the Bermuda Hospital Board. We'll provide an overview this evening. In Bermuda, as we well know, and all of us here know this, healthcare and the cost of healthcare are a priority, not only for the government, but for almost every member of our community. From the youngest to our most senior, affordable healthcare, access to quality healthcare, and the cost are at the forefront of public concern and a highly discussed topic, I'm sure, not only at the office, but also around the table. It is much discussion and conversation in our community right now, and tonight we will have an opportunity to ask questions and also hear the changes to the standard health benefit and funding for BHB. I'd like to take the moment to just acknowledge the Senate, Bermuda Senate President, Joan Dillis Wright, who I see, and the Vice President, Senator James Jardine. Thank you. We have a distinguished panel of speakers who are going to provide much clarity. Oh, yes, I didn't see, I'm sorry. MP Pat Gordon-Pamplin, it's so good to see you. Yes, indeed. Tonight we have a distinguished panel of speakers who will provide clarity on the standard health benefit and answer your question. Our panelists are the Minister of Health, the Honorable Kim Wilson, JPMP, who will give the overall presentation, the Permanent Secretary, Jennifer Attride Sterling, and the Acting CEO of the Bermuda Health Council, Dr. Ricky Brathwaite. The agenda for this meeting: first the Minister will make a presentation, and then we'll open the floor to questions with Dr. Brathwaite and PS Attride Sterling providing support and answers as well to your questions. But first we'll start with a short video that has been put together by the Bermuda Health Council.
Standard health benefit isn't about guaranteeing the establishment of business. It's about ensuring that everyone has equal access to services that are agreed upon as being essential. What do we consider essential? Well, ultimately, it's up to you. Standard health benefit and the premium that you pay isn't the Bermuda Health Council's money. This isn't money entitled to any insurance company or any specific provider. This is money that belongs to the people. That's a pool of $360 million that is set aside for every member of the 63,799 residents of Bermuda to have access to the kind of things that are necessary. We have found over time that maybe standard health benefit could be used better. We understand that much of the focus has been on care when you get sick instead of prevention. We found that there are services that you need that will help to keep you healthy, but you're finding a hard time to afford them. You've told us in telephone calls and surveys and letters and even emotional pleas on the side of the road that you want better support. You want to be able to afford your prescription medication. You want to visit your eye doctor or your dentist and not have hundreds of dollars in copays. You want to have a change of course in diabetes and hypertension and get local treatment for your cancer. You want to have support for your daughter when she goes into labor, and for that newborn in case they need to be flown overseas. This is what you've been asking for, and for it to be paid within that $360 million. We hear you, and now we're putting your thoughts into action. We now have an opportunity to close gaps, build bridges, and heal wounds. This is our opportunity to come together around a common purpose of better health and around creating a better health system for not only this generation, but for generations to come. This is indeed about your health, and this is indeed about your money.
Good evening, everyone. Thank you very much for joining us here this evening. As Tina indicated, the purpose of this evening's forum is to provide you with an overview and some clarity with respect to the issues surrounding the standard health premium, as well as the funding mechanism that will be utilized for the hospital. What I thought I would do is to provide an overview, actually, as to how we got where we are, and to provide information as to where we're going. So if I can allow you to just imagine that it's a train, and the ultimate destination is for us to be in a position where we can contain healthcare costs, we can improve access for all individuals at an affordable price, and to also ensure that we are doing what we can to improve patient outcomes. So in order to get there, that is our final destination, and we're taking steps to get there. With respect to this part of the presentation, I'm going to just provide you with an overview with respect to the context of Bermuda's health situation, the standard premium rate status, the Bhb funding change, health financing reform, and the Bermuda Health Strategy update. Okay, let's set the context here. We have some strengths and we have some challenges. With respect to the strengths of our system, maternal and child health is very strong with 0 maternal deaths and low infant mortality rates. Communicable disease control is very good with respect to good outbreak control. Life expectancy in Bermuda is on par with other high-income countries. And our healthcare, access to healthcare is at 98%. So 98% of all adults get regular health checkups. That's the strengths. Unfortunately, we have some challenges. Over 75% of our adult population are either overweight or obese. We have an aging population, and we have some challenges with respect to limited care options for long-term care. Chronic non-communicable diseases is very high. 35% of adults have a chronic disease such as diabetes, heart disease, or kidney disease. And we are spending on average per person $11,336 per year on health care. Our health system is not getting value for money. If you see Bermuda by the red arrow, we are the 3rd most expensive healthcare system in the world, yet we have a life expectancy ranked 13. So for as much money as we're spending, we should be higher ranking with respect to life expectancy. Our healthcare costs, like I said, it's over $11,000 per person. It consumes 11.5% of our GDP. If you look at that chart, the OECD average is the blue in the middle, and Bermuda is way over on the right-hand side. United States and Switzerland are the only 2 countries in the OECD that are leading Bermuda. Fortunately, Bermuda has bent the healthcare cost curve, and we averted a $1 billion fiscal cliff. The National Health Accounts Report of 2010 projected that if we didn't do anything quickly, that by 2017, we would be spending $1 billion on our healthcare system. So in 2010, the journey began to reach long-term sustainability. I'm going to give you some more statistics, which are somewhat sobering. 75%, like I said, of all adults are either overweight or obese. And if you see where Bermuda is, and you see in the middle the OECD average. So unfortunately, these statistics are somewhat dire, but it relates specifically to some of our healthcare costs, which I'll speak about in a few moments. 12% of our adult population have diabetes. You see where the OECD average is in the middle, and Bermuda again is on the far right-hand side, only taking Mexico and Turkey are higher than us. 54% of all adults have 1 to 2 chronic disease risk factors, either from smoking, low fruit vegetable intake, inactivity, overweight, or raised and elevated blood pressure. So the statistics are very dire. $78 million is spent on just 2 preventable conditions. So 10% of our healthcare dollars, which is about $770 million, 10% of that is spent on preventable conditions, 2 preventable conditions. So that gives you an overview of the dire condition that we're in. And those are some of the drivers of our healthcare expenses, because we've got, like I said, obesity and overweight, highest population, diabetes, chronic diseases. It's a dire situation, and that's why we have to do take steps to try to address that. And so those are some of the drivers of our healthcare cost. Utilization is increasing, cost of services, we have an aging population, and we have a chronic disease, high incidence of chronic diseases. So we have people that are living longer, sicker. So in order to set that context, we had to look at ways to try to address that. And these factors were the major drivers and considerations for us looking at the standard premium rate. So the actuaries assisted with respect to producing some numbers. And when they did the modeling, based on utilization and other factors, they realized that we would be looking at an $84 increase to the standard health premium. Obviously, that would not be acceptable to the public or to employers. That would have made the standard health premium $355.31, add $84 to $439.32, which certainly wouldn't have been acceptable. However, by streamlining the way that BHB is going to be funded, we are protecting the standard premium, and we're making it in such a way where the standard premium is going to be paying for health care only. So the health care dollars that are going into the standard premium rate are going to be paid and utilized for health care only. So the standard premium rate, as has been announced publicly, will not change. So last year the rate was $355.31. This year the rate will remain at $355.31. And what that means is that HIP and future care premiums will not increase in 2019. If you look at that graphic in the middle, with respect to the standard premium rate, we're able to do that because we're going to be changing the mechanism that we are using to pay for the hospital's fees, which I'll speak to you about in a moment. The dialysis funding is going to be blocked so that there'll be a set fee paid for dialysis. And then we're also going to be able to utilize some of the savings so that we can find space for chronic disease benefits. So as I said in that slide, there's no premium increases. Healthcare monies are protected for healthcare. The basic health benefits will be kept the same, so they will be kept intact, and fiscal space will now exist for chronic disease benefits. Bhb funding. So in order for us to be able to keep the standard health benefits the way that at the same fee of $355.31, we had to look at funding mechanisms for the hospital. Heretofore, the hospital operated on what's called a fee-for-service model. So that means that when you went into the hospital, and you would be charged a particular fee for the service that was delivered. Now, we note that hospitals throughout the United States and other jurisdictions are moving away from that model because it's not as efficient, and they're moving to block grant models, and that's what we're going to be doing with respect to the hospital. So we'll be transferring the mechanism of payment from a fee-for-service model to a block grant model. 46% of all of our health cost spending is on the hospital. And over 95% of the SPR spending is on the hospital. So the standard premium rate, the benefits package that comes under that, over 95% of those benefits are for inpatient and outpatient services at the hospital. And 46% of our total healthcare spending, that $770 million that I spoke about, 46% of that represents the hospital. So over the last 15 years, most of the components with respect to health spending have remained stable. So you can see the hospital is the blue one on the top, and the ones below, Ministry of Health, Prevention, Overseas Care, Local Practitioners, Prescriptions, and other. Those have all remained relatively the same over the last 15 years. So some people ask, well, why are you looking at the hospital first? Well, as I indicated from this graph and previously, 46% of our healthcare costs are with respect to the hospital. So currently, Bhb's funding mechanisms is comprised of the following. There's the fees that are charged to the public and private through the insurers. There's a government subsidy that goes to aged and youth, seniors, and indigent. There's a government grant that goes to the Mid-Atlantic Wellness Institute. And then there's the transfer from the Mutual Reinsurance Fund. And the objective of these various payment mechanisms is to ensure that the Bermuda Hospitals Board has sufficient funding to operate the hospital and MWI, as well as to be able to reinvest in necessary building maintenance and technology upgrades. And moving forward, the current system is volume-based, and eventually we're aiming to get to the value-based system. That is our goal and objective. However, as the note says, a mixture of payment systems is also recommended in any healthcare system to ensure that you're incentivizing desired behaviors. So the streamline, the block grant for the hospital, as I indicated, the block grant is going to be in the sum of $330 million. And by us transferring from a fee-for-service to a block grant and setting the fee, that block at $330, it's allowing us to prevent a $20 million added spend to our healthcare costs. And that will allow us to use monies for expansion of prevention and primary care. So in essence, we are preventing a $20 million added spend. Okay, so while the standard premium rate will stay the same, the Mutual Reinsurance Fund premium will form a larger part of the SHB. So if you look at the slide to the left, that's the current situation. So the SHB, you see, is $355.31. The Mutual Reinsurance Fund is the orange part. That's the $101.97. The green part is the supplemental benefits. That's what the insurers charge for their supplemental benefits. The part in which the government can control is the SHB part, the blue part. And from that blue part is the Mutual Reinsurance Fund. However, moving forward from June 1st, you see the SHB remains the same, as I said, $355.31, so future care and HIP will also remain the same. But there will be a larger transfer of that $355.31 to the Mutual Reinsurance Fund. The next slide probably is a better illustration. Yes. So the current position, the standard health benefit, as I said, is $355.31. Of that $355.31, $303.58 actually goes towards health care. If you look at the diagram below, you have the part in the yellow, which is the premium, $355.31, and that goes, $202.67 goes to the hospital and other SHB health care. That's standard health benefit health care, such as mammographies and certain diagnostic imaging outside the hospital. Then you have the administration and profit, $50.67. Then you have the dark blue, which is the Mutual Reinsurance Fund, and that helps to provide, that's a separate fund that's assessed outside the consolidated fund. It's not part of the consolidated fund. It is a separate fund called the Mutual Reinsurance Fund that is established to help pay for kidney treatment, dialysis, and so forth. And of that, currently, $101.97 of the $355 goes to the Mutual Reinsurance Fund. However, commencing June 1st, that same $355.31 you'll see the majority of that. You'll see $331.97 going into the Mutual Reinsurance Fund, and that's the fund that will be utilized also to pay the block grant to the hospital. And then you see that the SHB will retain the sum of $2334. I'm sorry, there are handouts back there, actually. I don't know if we're gone. Oh, okay, there are some handouts. And then the administration and profit is nil. So effectively, what we're doing from June 1st is that the SHB premium will be spent on your health care. Okay, I'd like to just spend a few more minutes about that train that I was speaking about in our destination. One of the important elements of health care reform is paying for it, because at the mechanisms that we're utilizing now are not cost effective. There's a lot of seepage, and we're not getting value for money. There should be no way that we're spending $11,000 per person, in excess of $11,000 per person, with the type of health outcomes that we have. So we have to find a way to pay for health care and be more smart about our payment. And that leads me to health financing reform. So back in 2012, well, prior to 2012, the National Health Plan of 2011 started the reform process. And at that time, there was a task group that was appointed to reform health financing. And that task group included actuaries, Harvard advisor who had worked with health financing reform in other jurisdictions, and you can see the members of the task force are listed on the left. So that task force got together and started looking at health financing reform mechanisms that were happening in other jurisdictions in the world. Following their meetings and consultation and deliberations, they came up with a report, and they narrowed down, out of all of the different types of health financing mechanisms that existed, they narrowed it down to 2. And that report was produced in December of 2012. So you see that in 2013, the National Health Plan was put in abeyance. And then in 2015, it was rebranded as the Bermuda Health Strategy. And then in 2017, we restarted the work again on the financing reform. So following the election, we picked up the report of December 2012 and looked at it again so that we can see, rather than reinvent the wheel, because there were a number of persons that had actually participated in compiling that report previously, we put together a stakeholder consultation group and asked them to look at the report and to go back to their own constituent bodies to see which of the options would probably be most preferred by their constituent bodies. So at that stakeholders group, we had persons from the healthcare profession, from IB, insurance, representatives from charitable organization. It was a cross-section of Bermuda representing various constituency groups. They reviewed the 2012 report and came back with some recommendations, as well as having spoken to their own persons in their constituency that they represented and said, these are the views that we have insofar as which option. So if you look at this slide, the 2012 group considered all of the possible options to finance health care, and they settled on 2 that were presented as the most viable to achieve the following goals. Reform goals: universal coverage, decent basic package, affordability, and cost containment, as well as the models that they considered: medical savings accounts, and these are models that are used in other jurisdictions throughout the world, but these are some of the ones that they looked at and considered. Model setting accounts, individual risk rating, national health service, a single payer system, status quo, and with a guaranteed issue and the status quo. And what they came up with is, following the meetings that they had, they came up with 2 models. One is called a unified, and one is called a dual. That's the current system. So you can see there's a possibility of inefficiency, a lot of seepage, a lot of wastage. That is the current system. The status quo will not do. We cannot continue to drive down healthcare costs with the system, the mechanisms that we're using now to finance it. That's not going to work. So again, the committee that I spoke about from 2011-2012, they came up with 2 particular models. So they reviewed all the models throughout all different jurisdictions, and they came up with the dual or the unified model. Now, both options improve the current system, and they both achieve the universal coverage that we were speaking about. So you can see from this graph They are very, very similar, and they both achieve the objectives that we spoke about concerning universal coverage, affordability, and the like. So again, they're called unified or dual system. So in order to improve health outcomes, access, and lower costs, we have to change the way in which we are paying for health care. And that's the best way that we're going to be able to do it. So we have to change it. So again, moving forward, that's the direction of travel, as I indicated about the train, is that we're going to be looking at health financing reform, and we will be addressing one of those two models. Right now, modeling is being completed as we speak to see the cost of a premium package based on certain parameters that we're looking at. So the government looks to be making an announcement in the not too distant future as to which model, either the unified or the dual, will be rolled out and we'll commence working on that. So the Health Financing Reform Initiative is led obviously by the ministry, and it's supported by the Health Council, as well as a steering committee and the stakeholders consultation group. So all of these partners together are assisting with the ministry with respect to the initiatives that I've just spoken about. So obviously the ministry is directing the policy based on the government's policy, and then these stakeholder groups are also playing a role, as I said, with respect to going back to their constituent bodies to assist with respect to concerning, identifying what some of the challenges may or may not be concerning unified or dual. Moving forward, next steps in the health financing reform. Q1, we're considering the stakeholder consultation group report. So like I said, we're waiting on the modeling. There was the stakeholder consultation group. They provided their recommendations as to which option they preferred, either the unified or the dual, and we're waiting on the modeling to be completed so that the cabinet can make a final decision. Q2 is when the cabinet will make the decision. Q3, we're developing a roadmap with consultation so that everybody can get a clearer understanding and a picture as to the direction of travel. And then Q4, we will start to implement in phases, again, with working groups and consultation. I think that's it. And I thank you for your time, and we will now have an opportunity to answer any questions. As Tina Evans indicated, I am joined by policy analyst, the acting CEO of the Health Council, Dr. Brathwaite, and the permanent Secretary of Health, Dr. Atride Sterling. Thank you.
Thank you, Minister. As we said at the beginning, we want to invite your questions. We thank you. I know everyone's worked, most of us in here, a full day, and we appreciate you coming out, and we're going to allow some time for everyone to be able to have a few moments to ask the questions. Now, I also recognize not everyone likes to come to a microphone, so I have two colleagues here who have index cards. If you prefer to write your question on an index card, you guys just come just so they can see you. You could just raise your hand and we can pass you an index card. You know, I love to say this at town hall meetings. We want people to have a chance to talk. So I'm asking you to please come to the microphone. The microphones are on either side. I'd like for you to allow 90 seconds to 2 minutes for a question or a comment. This will allow time for others if they wish to speak as well. We set aside about 45 minutes for Q&A and concluding close to 7 o'clock on or before 7:30. Again, if you don't wish to, just put up your hand and you can have an index card. But let us have good, healthy, respectable dialogue around this subject that many of us have talked about. Who's going first? To the microphone, please. Thank you. Good evening.
I show them my insurance card, they fix me up, they send a bill, I pay the bill, the insurance company pays the bill. Why did we remove that? Or are we removing that?
That's your first question?
That's my first question.
All right.
So good evening, everyone. So the answer to your first question, why remove the money from the insurance companies? So the money still resides with the insurance companies. Insurance companies are passing on that money to the health insurance department to pay for the hospital care. The difference in the model, which is currently happening, is that there is an imbalance between how much money each insurance company currently supports the standard premium rate. So for example, I'll give a simple example. At the beginning of each year, we say it's going to cost $100 million, and I'm using a simple figure, it's going to cost $100 million to support the care for everyone across this country to have hospital services. What tends to happen is that some insurers end up paying less into that pot that we know it's going to cost, and some insurers pay more. Some insurers actually don't have the money to pay, so we have to make up the money later on. So for example, and I'll be very clear, the health insurance department, their loss ratios when it comes to payments to the hospital, they're always in the red, right? They don't bring in enough money to pay for hospital care. But the point of having a fund, the standard premium rate, is that everyone puts their money into one pot and we pay for care together. That hasn't been happening, but there has been a payback on the back end. So what we're doing is taking the money up front and saying, this is the amount of money we need. Instead of paying back HID on the back end for money that they can't afford for that care, we're paying it up front. The insurance companies are still collecting that money, but they're all paying their fair share into this pot that we determined to be the cost of providing those services.
I can add, no, I cannot. Is this thing on?
Yep.
I can add a little bit to what Dr. Brathwaite said, described. The money was ultimately always destined for the hospital. Yeah? That's the reason the premium is set at that community rated rate. It kind of takes the average. This is what it will cost to care for the whole population. And the intent has always been that that money would go, well, 95% of it goes to the hospital. What this change is doing is making sure that that money does actually reach the hospitals directly. So it's taking a less circuitous route with less back and forth in claims administration and billing for this particular thing, and this was right and this was not. Ultimately, if you're insured, you will be entitled to that because you will have paid into the pot. So it doesn't matter whether you had a stroke or whether you had a broken toe, you have paid for the care and you're entitled to it. So small groups, say a small employer group, whether private or public, it doesn't really matter. If you have 5 people and one of them has a catastrophic accident of whatever sort, that group would be really deeply disadvantaged, yeah, if they're individually risk rated. By having a community rate, you're distributing the risk across everybody, and everybody is carrying the burden for the community. That is the purpose of community rating.
Follow-up question? Follow-up question? Go ahead.
So you said that I'm still covered by this catastrophic. If you happen in the hospital at 3:30, the hospital is not then going to have to use it?
No, the hospital is not, because the 330 revenue target was agreed very carefully with the hospital to make sure that over the next fiscal year they could continue to provide the services they have been. And we are absolutely confident of that. This year they did not have a deficit, and next year's revenue is going to be more than this year. So we are absolutely confident that it's going to be okay, and the quality of care is always going to be the prerogative.
Can you speak a little more into the microphone, please?
The insurance company that we are currently insured with, if they no longer have access or they no longer doing a claim to me, how
So there's been some misinterpretation of the discussions that have taken place. For the last 6 to 8 weeks, we've been talking directly with insurers on the mechanics of how this is going to work. The first time we talked about this, we said, we want the hospital data to come directly to you. Some insurers said, if we're not going to be receiving the money, we don't want the claims, right? So that was the first response. We came back to another meeting. The response to that meeting was, wait. That person doesn't speak for all of us. We actually want the data. So from the very beginning, our objective was always to make sure that each insurer had all the data that they currently are accessing from the hospital. There was some confusion within the ranks of insurers as to whether they wanted the data or not, considering the change in the mechanics. We've settled on, weeks ago, we've settled on that everyone's going to have access to their data based on what their clients, the services that their clients get in the hospital. That has been something that's decided on weeks ago. So any misinformation that has been provided is misinformation. It is not anyone's intent to compromise the care of hospital patients, to compromise the care of pre- and post-hospital care. The whole point of this whole exercise is to ensure that we have better care, we have better options, we have more money to pay for preventive and post-acute care. And so it doesn't actually make any logical sense for us not to allow insurers who care for you when you're outside of the hospital and wherever you go overseas to not have your data. And from the Health Council, who is data-driven, as we're talking and influencing these discussions, it has been our topmost priority to ensure that there is proper case management and proper accountability with the data that is available.
Okay. I have some questions from the floor. Some questions from the floor. And let's see if they work with some of yours as well. How does the funding, the Bhb funding, reduce healthcare utilization? And then there were some questions about doctors and physicians. When will physicians' fees be addressed? There is no cap on what they can charge. Again, let's finish with the Bhb and then we'll come back to the physicians because there's a couple of questions about physicians.
So the first question is around how will the fund affect utilization?
Yes.
So let's take the example of grocery shopping. If you have a budget, you tend not to buy things that are unnecessary. If you have a budget, you buy the core things and things that are necessary for the things that you need. It is a fundamental part of fee-for-service systems that you are going to utilize additional things because it is advantageous for you to get more revenue for doing more things. It is not a secret that within fee-for-service systems, whether it be here in Bermuda or other places in the world, that there are unnecessary things that are done. There are admissions that are made to the inpatient wards that are unnecessary because they pay higher amounts of money. But that is the business of healthcare. It doesn't mean that it's necessary to admit someone who doesn't need to be admitted because it pays you $10,000 more. And so we have a system that has been built on this for a very long time. It doesn't help from a clinical standpoint, it helps from a business model. So we are now putting constraints on the system and saying, look, this has to be about healthcare, this has to stop being about business. We have too many people struggling within our society that aren't getting the care that we need to make so many business decisions when people can't afford care. So this cap incentivizes people to do the right thing and to be more efficient in the care that they're giving, period.
So something to add to what Dr. Brathwaite said, something that having a global budget has done in other hospitals overseas. There is experience of this. We didn't invent this method of funding healthcare or funding hospitals, and it has been successfully implemented elsewhere. It certainly puts in place very positive incentives for any provider paid in that way, in this case a hospital, but it can be anybody, to actually get very creative in developing partnerships with other healthcare providers in order to really focus on delivering the right care at the right time in the right setting. And the hospital is not always the right setting. And the hospital now has an incentive to actually want to see that care delivered in the best way possible, because quality care is always going to be more cost effective. It doesn't overtreat, it doesn't overprescribe, and therefore it doesn't overutilize and overcost. So global budgets do actually put in place those favorable incentives that are much better for the system and much better for us as individuals than a fee for service, which is just a cash register mentality of doing more because every procedure generates a fee and generates revenue.
A couple of questions from the floor, and I see you coming there. And these are really regarding physicians. What is the thought process around a regulatory framework for private doctors and dentists on island? Could possibly do away with high copays and unnecessary testing if there is a regulatory framework? When will physicians' fees be addressed? There is no cap on what they can charge. And why not stop self-referrals that doctors do to their own services? Pharmacies, diagnostic imaging, and there you have it. Those are the three on physicians.
Okay. From a policy perspective, the government decided to start with the area in which the highest healthcare spend is, and that's the hospital. 46%, like I said, of the $770 million is used for the hospital. However, moving forward, again, on the direction of travel, those are issues that we are going to look at insofar as how we can address the issue concerning copays, the issues concerning physicians' fees, self-referrals. Those things are in situ.
Anyone else on physicians, doctors?
Yeah, I can add on to what the minister just outlined. It is true that there isn't sufficient regulation for fees that are not within the standard health benefit. There are very few fees outside that regulated package. And historically, that's the way that the Health Insurance Act is structured, which lays a foundation for our entire health system. And it doesn't provide for the regulation and setting of other fees, which is what leads to a lot of variation in the way that practices choose to run. In order to regulate more of the fees, a number of things need to happen first. You can't just go and place a fee artificially. There has to be, in addition to a lot of consultation, there has to be a clear logic as to why the fees are being set in a particular way and why these and not those. You can't just cherry pick. There has to be consistency. And that consistency in system is exactly what we're working on developing through the Bermuda Health Strategy and through the health financing reforms. So there is already work being done at very advanced stages to bring logic and better regulation, better fee setting for the fees that doctors and dentists can charge for work at the hospital. That work will be released very, very soon by the Bermuda Health Council. And there is also the work at very advanced stages to regulate pharmaceuticals. The Bermuda Health Council is also advancing this work to have a formulary of the most commonly used and necessary drugs in Bermuda, to have a set price with a regulated copay and dispensing fee that is much more affordable. And then there are other components. Yeah, so as the minister said, you roll it out. We're starting with Bhb because that is immediately within our control. The regulations are already in place, and then we expand it out to the new areas. And eventually, there will be greater regulation of any fees that are within the standard health benefit. And in the long run, the hope is that there will be more benefits within that basic package so that it can actually provide genuine, proper protection for persons. And it's a stepwise process. And as the minister said, there's going to be, the train has left the station and we're moving in that direction, and there'll be a lot more dialogue over the coming year on that.
All right. Sir? There you go. Thank you for your patience.
Good evening.
Good evening.
I hear and understand the argument regarding the way physician and the more you build, the more money you make. annual fee. However, the other side of the coin on over-utilization is basically anybody can show up at the hospital and get care, whether they have insurance or not. So don't pretend that people would stop buying insurance, but why bother buying health insurance if all you need to do is go to the hospital and get free service? And also, like, why every time somebody is sick, like, just show up at the hospital? Why is it?
No, it's a good question. Yeah. No. Thank you for asking.
Right now, your insurance company might give you a hard time if you're trying to get an MRI and they don't need one, or when you try to do something that's not within the accepted treatment, treatment or something, you're going to get a hard, your insurance company is going to give you a hard time. But you can push it further. Why buy health insurance?
Correct. Do you want to comment,
Right.
Ricky?
So I think one of the good things that we've done within the system is provide subsidies for the indigent. So I think part of the wonderful thing that we do is protect those who are most vulnerable. Within the new system, healthcare at the hospital isn't free. For those who aren't paying into health insurance or aren't paying into that fund, what will happen is there will be, in essence, a check to see whether you paid into the fund or whether you're insured. And if you don't fall under another category like subsidy, what will happen is that you will receive a bill much like you do now. So if you're not insured, you're not under subsidy, and you show up in the hospital, of course you'll get great care if it's an emergency situation. But if you're not insured, there has to be some funding found for you, and unfortunately, in some of those cases, you will receive a bill from the hospital. So it's not an incentive to show up at the hospital and drop your insurance, because you'll end up with a bill. But we want to avoid that. What the goal of all this is to develop universal health coverage where everyone's insured, and if there are mechanisms by which those who can't afford to purchase insurance, we have to work as a community towards providing some options for those individuals. That's more so the goal.
So to answer the question, or rather to shorten what Ricky described, in the current system, the hospital receives the list of insured persons on a, what was it, daily?
On a daily basis.
On a daily basis. So they know who is insured and who is not. And then if somebody is not insured, they make an assessment as to whether they cannot afford insurance, and then they receive indigent subsidy. And with the new funding, the same thing will happen. They will receive the list of who is insured and who is not, and so they will know who they have to bill and who they don't.
Am I? MP Gordon Pamplin, just before you go, I have another question from the floor. Will the two models that you spoke about, Minister, I believe, unified, dual, be close to full comprehensive, will be close to full comprehensive insurance, i.e. ambulance, overseas care? And I hope I did justice to that. Yeah.
Yeah. The models that I spoke about with respect to unified or dual don't relate to the actual benefit package. I think what that question is
Okay.
indicating is when you speak about the benefits, that's a package. That's an insurance package that includes benefits such as orthodontist, a benefit package, eyes, whatever. The model that I spoke about is how we're going to pay for our health financing reform. So we need to look at how we're paying for reform. So in other words, if we're looking at a unified versus a dual system, it's effectively allowing all of the people, the 48,000 people, to be put into one pool, so to speak. And whether it's dual or unified, again, decision has been made, but it's how we're going to finance the cost of health care. It has nothing to do with the benefit package. That's something separate. The modeling that I spoke about with reform deals with how we're going to be paying moving forward for the healthcare system.
Okay?
I can
Oh,
add
go
to
ahead.
that, Tina, because the question is obviously very good, and although either model doesn't, either model will be able to provide and cater to an enhanced benefit package, which is what I think the question is asking. Am I going to get better benefits if the system is reformed? And the answer is yes. What that package looks like is going to be a matter of public dialogue and consultation. That is the modeling that the minister was speaking of, because obviously if there's going to be a change in the package, people will want to know, well, how much is it going to cost me, and how is it going to be paid for? And those are the answers that we need to have ready at hand. The intent is for this package to include more than just hospitalization, but to actually enable prevention and taking care of chronic communicable diseases, to prevent the revolving door at the hospital because conditions aren't addressed. So we definitely need to have pharmaceuticals. In the long run, ideally, it should include some overseas care for medically necessary care. I don't envisage that it will ever be a package that covers everything, because right now comprehensive packages in Bermuda are very, very, very generous. And if Bermuda went that route, well, it would be a very big package. So certainly in the first instance, there isn't an expectation that it would be as much as comprehensive, but the view is that over time it will become a very decent package that will keep you healthy when you're healthy and will get you better if you have an event like cancer or stroke and you need overseas, the premature babies, and so on.
And just to add on to that, there will still always in either of the options be the ability to buy supplemental coverage. So right now we've been talking about the response was referring to the base package. What would standard health benefit look like in the future? So if we have, for example, primary care included in pharmaceuticals, that would be part of the basic package, but that doesn't preclude you from going out and purchasing a supplemental package for air ambulance or dental care, things that may or may not be covered ultimately in that package.
All right. MP Gordon Pamplin, and can you speak directly into the mic? Thank you. Yeah. Thank you.
Thank you. I just have a question. At the moment, in respect of the standard premium, you've indicated that now a significant portion of that standard premium will now be taken out of, will go into the mutual insurance fund for onward transmission to the hospital for the provision of hospital services to the tune of $330 million. My question is, what happens in terms of payment for a service that is, the money is being sent up to the hospital, but that service is now being provided for outside of the hospital, such as, let's say if I get an MRI, the money is going to the hospital has the money for my MRI, but my physician, because of timing or availability, wants me to get my MRI at an outside service. What happens to the payment for that fee to the outside provider? Because the money has now gone to the hospital.
Yeah, the whole of the MRF is not going to, of the mutual reinsurance fund premium is not going to the hospital. There's going to be premium remaining with each insurer to pay for the non-hospital services. So if you have your mammogram at Bermuda Cancer and Health, that is a standard health benefit, and that will be billed to the insurer exactly as it is now. So they are retaining premium to cover those.
So let me just get clarity, because the retention is going to be somewhere on the order of $25 up to $355. So if a significant number of services that are available at the hospital are being provided by outside providers, those outside providers will be billing the insurance companies for money that the insurance company through the MRF have already sent up to the hospital.
That won't happen. We know the claims experience for the services outside the hospital, and so the premium has been adjusted and allocated to meet that claims experience, historical, and the projections of use. I don't know if you want to add anything, Ricky.
Well, I guess just because I need to clarify in my mind based on questions that have been asked of me, the $25 that's left has to pay for everything else that's included in the standard hospital benefit. I do know...
Because it's not very much.
Well, it's not very much, but my question is that given that the actuarial determinations were that the standard premium should have been significantly increased. How are we satisfied to know that the $25 that's been left over is adequate?
There's two parts. There's, historically, our actuaries have been pretty on top of their game in terms of assessing the system because they've been doing it within our system year after year. The money that they have determined to be spent on things like MRIs, CTs, X-rays, ultrasounds, home medical services, those kind of services, they've actually modeled the trends for the last 5 or 6 years. They've added some additions for utilization for this coming year. So they've taken into account the potential for added use of those services outside of the hospital. This is a process they would have done every year. If your concern is more so that there may be additional services that were not accounted for by the actuaries, that is a risk every year, right? So it is a scientific per se process, but there is some uncertainty always that's built into the actual premium. So for example, the actuary says 99% of the time this is going to be about how much you spend, but we'll give you 5% on either side to say you may spend more, you may spend less, and we're going to use less, and we're going to build that into the premium. So they've built in the potential for added use of those services versus what's already been spent based on the trends, right?
Yes? There you go. Senator Jardine.
I have a few questions. The first question is, the minister mentioned earlier in her comments that there were approximately $20 million in potential cost savings as a result of this change. I hope I got the number correct. Could you give us some idea as to how that is calculated, what that is based on? That would be useful, thank you. The second question is, once the $330 million cap, or if the $330 million cap is exceeded, where will the additional funds come if that happens? Will that be an additional supplementary through government to the consolidated fund? I know this is the first time that we've done this, the 330 cap, so it's a bit of an unknown quantity, but I just wanted to know if that is exceeded, what happens? Is they coming back to government for further sums? Those are my questions. Thank you.
So the $20 million, based on the actuary looking at the trends of hospital utilization and how much is being reimbursed to the hospital, the projection for the hospital was going to be around $350 million that they would bring in, right? So through fee-for-service, through doing services, it was expected the hospital would bring in $350 million or so. What tends to happen at the end of each year, we look at the experience and say, were we right on the projections? And usually every year we're between 96 and 104%, right? So if we say we're going to spend $350, we're about 4 or 5% either up or down on that number. So typically we're pretty spot on as to what was going to be spent in terms of projections and what actually happens based on the actuarial analysis. So when you talk about savings, we're not talking about there was $20 million that was spent and we're saving. It's a prevention of what was intended to happen. And when we say potential, it's how strong was that potential going to be? And the actuary says every year, based on their calculations, the potential was going to be pretty strong. And again, if we go back to a previous answer that I made, you can, if you set targets within a fee-for-service system, you can find ways to reach them. So part of that is not only capping, but also, so we're capping, but we're also holding the providers accountable to work within that cap.
So on the second question of what happens if the 330 million is exceeded, which is a very good question, obviously, and a concern more than anybody for the hospital. And we did consider that. And in the long term, I mean, this is an interim year. Having a very solid cap in that way is a very crude measure. But even for a global budget method, we need to have something more, we need a year basically to work together with the hospital in a more sophisticated way of having kind of a cap and collar amount to give us some flexibility up or down, right? So that the hospital is not bearing such risk. But for this fiscal year, we, together with the hospital, are confident of the figure. And in the event of any slight slippage or discrepancy, the hospital has $65 million in surplus that may be required to be used. We certainly hope that's not the case. And should there be a national catastrophe, if there is a pandemic or something that really drives utilization in a way that is totally unexpected, then of course the government is going to step in. The government is the guarantor to the, well, the, what is it called? To the acute care wing. So the government is always on the hook anyway.
We'll offer you an opportunity. Anyone else would like to ask a question? Could you please, how are you this evening? Would you please come to the microphone? Thank you.
This is on future care.
Okay.
Do you have any provisions to include urology in future care?
Whether urology is going to be included in future care. Urology right now, well, not right now, urology is not within the standard health benefit at present. And if it were added, it would increase the premium. So the challenge that the government has every year when it wants to consider increasing pharmaceutical benefits, for example, or adding urology, or having higher fees for specialists so that the co-pays are not so large, the challenge is always, well, we would have to increase the premium. So we're stuck between a rock and a hard place, and that is one of the dysfunctions of the current structure of our health financing. That first diagram the minister showed, the map of the financing that is just bleeding and leaking everywhere. You can't sail like that, right? You're bailing water and it's coming into a sinking ship. That's why we need fundamental structural reform of the system so that we can add benefits without any one insurance plan or any one insurance pool being dragged under, or the premiums really affecting just one pool of population. It has to be shared. The risk has to be distributed so that everyone can be covered for urology. Right now, future care doesn't cover it. As you know, it doesn't cover it at the hospital, I should say. It does cover specialist care, and specialist care in the community would be covered to the rate as any other specialist. So there is some level of coverage. When the new package is introduced, that's where we hope to see urology added.
Did you get all your questions done? Do you want one or two more, or you're okay? Come on. It was, yes. You were gracious to yield to to the audience members.
Probably straightforward questions. This is still scheduled for June 1st.
Correct.
Yes.
So on June 5th, I have to go to the hospital. To ensure that I'm insured, do I still need an employee to show the insurance card? Do any of those things change, or is that basic process the same?
Correct. Basic process is the same.
Basic process stays the same.
Okay. We have a few more moments. Now's your time. Yeah. No? All righty then. I guess we are, anything you'd like to say in closing, Minister? If not, I think we're, anything else? Oh, wait. You want one more? Come on, one more. It's okay.
You spoke about preventative medicine. What's going to be done for preventative medicine? How is that going to be tackled, challenged, so that we can't stop the aging of our population, but how much can that be tackled and changed?
We can age more healthily, for sure. We can age more healthily, definitely. Ricky, do you want to comment on that? Yeah.
So one of the added benefits of, in essence, creating fiscal space. So fiscal space is being able to find a little more room to do something, to add some flexibility. In the new, starting June 1st, there will be money that's set aside for chronic disease management programs. It's an innovation fund. It says if there are programs within the community that are preventive in nature, evidence-based, what we can do is help to fund those programs. If there are social networks that we can build to help seniors to be more social and reduce stress, those are programs that we can look to fund. We understand that there's a lot of social determinants of health. There's a lot of risk factors within our communities. We have to start looking well before someone develops symptoms and address some of the issues that individuals face by looking at some programs that work. So there's a lot of evidence in different countries as to what innovative kind of ideas can be brought to the table. And so we're going to be looking to the communities to help to talk about prevention and what could be prevention for you, and to put some money aside to help to prevent, right? So we're looking for flexible approaches. We know that there is no one size fits all, and it's unfair if we create just one program and it doesn't work for some people. We're trying to be as flexible as possible because we know everyone's needs are important and everyone's needs need to be met.
Great. One more, that microphone. Come on.
Is there any incentive going to be provided for people who lead a healthy lifestyle and are fit and are trying to remain fit? Because, as you said, 75% of the population is obese or thing. The other 25% is subsidizing it in one way. So is there going to be any kind of incentive for people to stay healthy?
That has been a dream of mine for some time. No, it definitely is. If there is a larger pool, it would be possible to create a system whereby if you meet certain metrics, certain behavioral and outcome metrics, you could be in a lower premium bracket. That would be possible. The thing is that everybody needs to be need to have a community rated pool, otherwise we end up in a situation where the young and healthy pay very cheap premiums and the elderly pay very expensive premiums, right? That needs to be equalized by putting everybody together in a pool, and then we can look at a measure like that, where if you meet certain metrics, you're a non-smoker, you have a healthy body weight for height, and so on, you don't have high blood pressure, high cholesterol, and so on, measurable things, then it would be ideal to be able to give those persons a lower premium rate.
So one of the things that we've talked about internally at the Health Council for our employees is actually putting together some metrics. And if you meet those metrics, what we'll do, or what the concept is, that instead of 50% of your health insurance, we'll contribute more. So less comes out of your pocket if you meet some of these metrics. So those are some of the innovative kind of ideas that I think employers and the insurers, I know insurers do give some discounts if you meet certain metrics or participate in wellness programs. But we need to make it more global in terms of everyone having access to those kind of programs. And the reality is, when it comes to what is the incentive of you being healthy, each of us being healthy, it only starts with one person, right? If I go to my friends and say, eat some more fruit, that actually makes a difference. So it's kind of that each one, reach one. It's really each one, teach one, but we can make a difference by just doing something different ourselves. And by each person doing something different, I think that 25% will grow and grow, and hopefully over time we'll, 35%, 45%. We'll get healthier over time. I believe in it.
Well, I wish to thank you all for coming. I know it's been a busy day, but by your presence here tonight, you, of course, solidify what we already know, that healthcare is a priority to all of us. And moving forward, you can expect more consultation, more dialogue with the Ministry of Health. Thank you again, everyone, for coming.